Civil 20, India 2023 envisions a conception of civil society 2.0 in a world where individual, family, society, market, and state can understand their respective roles better and supplement each other rather than engaging in conflicts. This year, the C20 symbolizes the flame of hope, self-motivation, and selfless service.
Amma is grateful to the Indian government for arranging such a high-quality meeting. All the issues raised here are vitally important. This should go beyond a mere physical meeting and become a true meeting, a meeting of hearts and minds. This is the only way to awaken ourselves and others.
This year, C20 working groups will focus on integrated holistic health, mind, body, and environment. Sustainable and resilient communities, climate, environment, and net zero targets. Education and digital transformation. Gender equality and disability. Technology, security, and transparency. Lifestyle for environment. Preservation and conservation of traditional arts, crafts, and culture. Human rights as human values. Revival of rivers and water management. Seva, sense of service, philanthropy, and volunteerism. Vasudhaiva Kutumbakam. The world is one family. Diversity, inclusion, and mutual respect. SDG 16 and promoting civic space. Delivering democracy through participatory governance.
Good evening all. I'm Dr. Jaydeep C. Menon, the co-chair for the Health Working Group of the C20 2023.
Namaskar everyone. I'm Dr. Priya Nair. I'm a gastroenterologist at Amrita Hospitals, Kochi, and I'm also co-chair for the Working Group on Integrated Holistic Health for C20.
As you would be aware, the C20, Civil Society 20, functions in the backdrop of the G20, for which India is the chair for this year. The C20 functions as a mouthpiece for civil society, voicing the concerns of civil society organizations, non-governmental organizations, and society in general. Our mandate being to draft policy documents called policy packs based on the inputs from CSOs, NGOs, and experts like you all.
We have an incredible list of eminent speakers for this introductory webinar, all of them doyens in their respective fields in public health in particular. They will give us a broad overview on key issues in their particular health domains. We have limited time and each of our speakers will only be speaking briefly for around 5 to 10 minutes. So we will not be taking any questions during this webinar. You will certainly have opportunities to ask questions in the future webinars and other events. So our first speaker for this evening is Dr. K. Srinath Reddy, a cardiologist, public health expert, and the founder, president of the Public Health Foundation of India. We are so honored to have you here with us, sir. I request you to share your thoughts.
Thank you very much. Clearly, when we are looking at the whole spectrum of health conditions that require attention, both at the policy level and at the level of community action, we recognize that non-communicable diseases are a very important contributor to disease and disability. about 75% of all global deaths in 2020 were accounted for by non-communicable diseases. These include heart diseases or cardiovascular diseases, which actually also encompass heart attacks, stroke, and disease of the peripheral blood vessels. We recognize that apart from cardiovascular diseases, cancers, diabetes, chronic respiratory diseases, kidney diseases, liver diseases, and a variety of other conditions, which are generally termed as chronic diseases, but can have acute manifestations like fatal heart attacks and acute paralytic strokes. These constitute the whole burden of non-communicable diseases. But while we recognize the overall global burden, it is pertinent to note that 77% of these occur in low and middle income countries. And 86% of the deaths in the 30 to 69-year age group, which is considered premature mortality by the WHO and the United Nations, occur in the low and middle income countries. Therefore, deaths in the productive prime of midlife affect the countries who are most dependent upon economic productivity for the younger age population. But even below the age of 30 years, we see children struggling with crippled valves due to rheumatic heart disease or childhood cancers. And about 70, what could have been a healthy aging is thwarted by non-communicable diseases. So we do require action across all the entire life course. And this becomes very important for us to consider that non-communicable diseases are driven by a number of risk factors which have been identified, whether it's high blood pressure, exposure to active and passive tobacco consumption, or lack of adequate physical activity, and of course, very importantly, unhealthy diets, exposure to air pollution, and stress, lack of adequate sleep. There are many of these risk factors which have been really identified, which operate at the individual level, but are frequently conditioned by the social, economic, commercial determinants of health. And therefore, we need action at all those levels. But we also have begun to recognize that the distinction between non-communicable diseases and communicable diseases is a bit flimsy, because there are cancers, for example, of the cervix, for the liver, for example, which are caused by infectious agents, and much more importantly, the microbiome, which resides in our gut and elsewhere in the body, is an agent which can provide us protection against various health disorders, or when disordered, then can spur inflammation, which can result in extensive damage to many organs, resulting in non-communicable diseases, among many others. So we recognize this connectivity that exists, and the reductionist approach to risk factors and risk determinants is not appropriate indeed any longer, even at the current state of our scientific knowledge. We do recognize that many of the people who are currently burdened are people who can ill afford the healthcare, which is expensive if the disease is advanced. Contrary to prior suppositions, this is not a problem of the affluent countries or the affluent and the rich in the poor countries. Over a period of time, the social gradient has reversed in most parts of the world and is reversing actively even in India and several other low and middle income countries. And we see that ultimately the poor among countries and the poor within countries are the most vulnerable victims. And therefore, it becomes absolutely imperative for us to provide solutions which are able to protect people across the entire life course. And we recognize that there is acquisition of risk in the newborn due to inheritance of risk, both due to genetic and epigenetic factors. And this particularly has been seen in cardiovascular disease and diabetes. In child, early exposure to risk factors in terms of unhealthy diets, secondhand smoke, air pollution. In adolescent, experimentation with risk, augmentation of the risk in the young adult with increasing risk behaviors and neglect of biological risk factors, even as hypertension and prediabetes set in at an early age. In terms of the manifestation of risk in adulthood, we see cardiovascular events and diabetes coming in with death and disability, and in older adults, recurrence of events. And we do need to ensure that all of these risk factors, which ultimately stoke inflammation and blood clotting or other forms of deranged metabolic function, are controlled adequately by addressing several of the risk determinants and early recognition and control of risk factors. Therefore, action lies at the policy level, at the health system level, where we need a multi-layered, multi-skilled health workforce, especially in primary care, for early recognition of problems and appropriate prompt response for care before risk factors advance to disease. At the same time, we do require programs to be established with a specific intent of detecting and controlling high blood pressure, diabetes, and other risk factors, which, if neglected, can lead on to severe disease. And we do require active community engagement, because it is imperative that people are enabled with the right kind of health and nutrition literacy so that they can promote their own health, protect their health, and preserve it, and not succumb to these diseases because of lack of appropriate knowledge. But we also need the community participation in order to ensure that policies and programs that have been initiated are successfully implemented and monitored by community participation. We do recognize that it is important for policy to enable people to undertake healthy behaviors, to make and maintain healthy choices across the life course by removing several of the socioeconomic barriers which prevent them from adopting the right course. At the same time, working affirmatively and with a firm intent to control the commercial determinants of risk which are driving unhealthy behaviors, whether it's tobacco consumption or diet, being very unhealthy in several respects of ultra-processed food consumption and so on, while ensuring that the healthier options like healthier diets and amenities for physical activity at the school level, at the work site and the community level are available, and air pollution is reduced. So I think it's absolutely important for us to recognize that there is so much of connectivity within the body, between human beings, and with the various environmental determinants of health, which has not been adequately acted upon by reductionist approaches that most countries and people have followed in the past. So it is absolutely essential that we bring in a much more holistic understanding. And indeed, the idea that we are shaped by our diet, our exposures, our various habits, our achar, vyavhar, all of that is very much embedded in Ayurveda and many other traditional systems of medicine. It is essential, even as we recognize the importance of action on the consequences of risk factors which manifest as disease through appropriate health system interventions, that we tackle the various drivers of risk, and particularly in terms of the determinants of risk which operate at the societal level through appropriate policy interventions. But even at the level of the individual, we cannot consider in a reductionist mode purely organ-oriented approaches. And therefore, the whole idea of building in that kind of a holistic understanding by blending the knowledge and wisdom that we have across multiple systems of healthcare and health and medicine would be very appropriate. And this is something that C20 should prioritize highly on the agenda. Ultimately, we recognize that the determinants of our health extend from the pulse to the planet. And therefore, it is that level of holistic understanding that we must bring to bear as we address these challenges, but ensure that at each level of action that we can undertake, we do take fairly well-focused and effectively implemented action. And the conglomerate of those actions will ultimately determine how successfully we can, at the global level, bring down the challenge of NCDs and spare the burden of death and disability in early to midlife. Thank you very much.
Thank you, sir, for your insight. You've, in the brief time that was given, you touched on the magnitude of the problem that we are up against vis-a-vis non-communicable diseases, the drivers for non-communicable disease, the possible ways towards mitigating the issues for the future, and also the deficiencies innate in the reductionist system that we now follow, and whether we could move on to a more holistic life course approach to disease. Your words are valued, sir, and all this is being recorded and would definitely be kept in mind when policy is being framed. Thank you, sir. We now move on to the next speaker. Dr. Narendra Kumar Arora is a pediatrician by training and was the head of the Department of Pediatrics at All India Institute of Medical Sciences, New Delhi. He currently serves as the Executive Director of the Incline Trust International and is also the chairman of the NTAGI. Over to you, sir.
Namaskar. Namah Shivaya. Really honored to be invited on this panel and share some of my thoughts for child health particularly, but part of it for maternal health as well. I will like to continue from where Professor Srinath Reddy has left and try to link and this whole issue of life course approach to human being. COVID-19 pandemic has shown us that things can get derailed even in the best of the circumstances, and even in the best of ecosystem, in the most high income settings also. So when we talk about low and middle income countries, that it is, one can just imagine what could be the degree of a kind of a destruction or derailment would have occurred, particularly for child health. It can be imagined, and in certain parts, one of the first things which has been affected is immunization coverage, but all the other child health interventions which are important both for improving the mortality as well as reducing the morbidity, these have been derailed. Now, one of the important issue is that in the context of recent years, a lot of gains which the countries, particularly low and middle income countries, had achieved, they have lost. What is to be done? Clearly, in an environment where even the incomes of the countries and the individuals have gone down, what is to be done? We know that the resources available, the manpower available in our kind of settings is not going to improve. It is going to take time. And therefore, we have to evolve a method, evolve a process by which within our limited resources and whatever our available resources are there, how best we can utilize, how efficiently we can utilize. And here comes this concept of implementation science. If I have a monthly income of 20,000 rupees, I have to work the whole family within that 20,000 rupees. I cannot think about a lot of other things which I may feel desirable, but within that 20,000, I have to live. I have to have a decent living. I have to have a healthy living. I have to have proper nutrition. And in the same manner, I think health system, particularly the fragile health systems, have to learn that how best we can work within the available and existing resources. And here comes the whole process of implementation science. And I feel that we have so many very effective interventions available, proven interventions, but they are not able to reach up to the people because we have not used this tool of implementation science. And so one of the first recommendation will be an action point that throughout the low and middle income countries, I think we should take this whole the issue of implementing available interventions in a manner that we are able to do it with available manpower, available money, available other resources in the best possible manner. My second action point is about redesigning the whole child health. Currently, we focus only on first 2 years of life, at best first 5 years, that is primary school or preschool age group, where vaccinations are given, where there some contacts with the health system for health being healthy and being well. But we find that practically between 5 years and 18 years, there is no contact. It is the missing middle. We have forgotten this age group. And particularly what Srinath was saying, that the whole foundation of our lifestyle is formed during this period. Our basic healthy habits, whether we are talking about mental health, we are talking about substance abuse, this is the age which is completely missed out. And I think the world has to wake up to this issue, that this broad a kind of a gap in child health needs to be immediately taken care of. There needs to be visits, contact with systems, so that this whole concept of health and wellness can be communicated to them. The other issue is that this is the age which is formative age. They are exposed, and we keep on talking about so-called globalization. But I think the era has come, and particularly in the context of what Amma keeps saying, that globalization has to be contextualized and it has to be culture sensitive. And then only we can move forward in a way that the quality of our lives will be more meaningful, more productive. Another important issue is that when we are talking about life course and when we are talking about children, the mother is totally forgotten. In fact, we know that when mother gives the delivery takes place, most of the ask, how is the baby? And people forget about how is the mother. And this convergence and continuity of care is the other issue. And therefore, if we have to really follow this life course approach, the mother and the child linkage has to be stopped. And that's my third action point. I will stop at that and summarize that we need to really take up the current interventions effectively implemented through implementation science. Second, the gap in childhood, where there is no contact with the child between 5 and 80 years, and the child health has to be redesigned. And the third is gap between mothers and the children, that continuity has to be built in. Thank you very much.
Thank you so much, sir, for your interesting words. Your points on the need of focusing on implementation sciences, the vital need of maternal health, and dealing with forming positive, healthy habits during the formative years are really very important for all of us to keep in mind, especially as we go through the further discussions to write a policy draft. I'm now honored to introduce, well, she requires no introduction at all, Dr. Kamala Krishnaswamy. She is a physician by training who went on to work in the field of nutrition and was the director of ICMR, the National Institute of Nutrition. She is currently associated with the Madras Diabetic Research Foundation. And as most of us probably already know, Madam has just received the Living Legend Award of IUNS in 2022. We are so incredibly honored to have you here with us today, Madam. Over to you. Madam, I think your mic is still muted.
Okay.
Yes.
Thank you very much for that very sweet introduction. I don't know whether I really deserve everything which is mentioned over there, but I would like to present some slides because that's an easier way which I can express myself better. So shall I start sharing the screen? I promise that I would talk not more than 10 minutes.
Please do, Madam. Please share your slides.
I'm sharing the screen now. Is that there? I don't know.
We can see your desktop.
Desktop. Oh, I'm sorry. I don't know.
I think you just have to minimize it in the red spot on the corner. If you close this.
Let me stop sharing, then I will start share screen and then go down and, oh, it's not there now. Okay, it's on behind, I think. Oh, I'm sorry. Vijay Kuprama. No, I'm not able to share, sorry. Well, let me speak offhand, and I thought I'll present to this group the importance of a healthy diet. And very few people, they know about the healthy diet, but rarely speak about it to the common man. And it is the NIN's responsibility to bring out a dietary guideline for the entire population. And it speaks of about 16 guidelines. And then we would, I thought that that's the one which I thought I will share, but unfortunately I'm not able to. So let me speak offhand. Now, a healthy diet consists of actually carbohydrates which are not refined, which are non-glycemic carbohydrates with plenty of fiber in the diet. And then the quality of the carbohydrates is extremely important here. And that's where perhaps people are not aware of it. And everybody takes the white rice. And it's very difficult to change this habit. We had been trying to do this from, of course, the MDRF in Chennai, which is one of the institutes of Dr. Mohan. I thought he would be here, perhaps he's not here. But that's what we wanted, and it was very difficult to change the habits to brown rice. We almost replaced the white rice, but anything about 50% of the plate should consist of only the brown rice, and the white rice should be 50%. Then probably we can bring down the incidence of cardiometabolic risk factors easily in a population. Certainly, there is a need for increasing the protein content of the diet. That's extremely important. That's where I wanted to present the new dietary guidelines. I don't know why I'm not able to share. The most important thing is, of course, to look at their diets, what they are using as their protein. Can you see that now? Can you see this thing? Slide?
No, madam.
I don't know what's happening. Just 1 minute, please. So I thought I will share today with all of you what exactly has to be done with the diets and what is actually a healthy diet. And then I go on to the dietary guidelines very briefly. I was in chair for developing the very first dietary guideline early in 1998, and it was updated in 2011. But now we would like to do the third volume of the dietary guidelines, and I thought I would just share some points in it and then see the whole thing. Now let me first. These are the components of the healthy diet, and we need to have quality proteins from legumes, pulses, some amount of lean meat. When we are developing the dietary guidelines, we have kept in mind even the climate change as an important factor, because we cannot be wasting land and water, and therefore we presume that probably millets to a certain extent can be a replacement for the white rice and refined wheat. Then we have to concentrate on good quality fats, which are low-fat dairy and nuts and seeds and plant oils. This is what we are using, but totally an unsaturated fat like which provides only the N6 is not advisable. You should have good quality fat which contains the mono and the N6 and N3 fats. What is lacking in our diets is plenty of vegetables and fruits, which provide the vitamins, minerals, phytonutrients, and fiber. Unfortunately, the vegetable and fruit intake, I'll show you the slide now, they are not being taken in large quantities. Even we are prescribing 500 grams of vegetables and fruits, raw vegetables and fruits in a plate. I will present a my plate concept with minimal processed food. And of course, the HFSS foods, that is low salt, sugar, and fat, and snack foods have to be taken in moderation. I would prefer that it is completely avoided. Now, this is the my plate for the day for the 2000 calories. Why I am presenting these dietary guidelines is it should actually receive a wide publicity, not just the community, but also all the people who are concerned with the health sector. This is the most important thing. We have been trying to do this by behavioral change communication methods, but still I think we have lagged behind for somewhere, and now the third volume gives even the diets as such, what has to be taken from, shall I say, from womb to tomb, because the mother has to be well nourished to deliver a baby of not of low birth weight, but adequate birth weight. Then several of these things can be avoided, particularly the non-communicable diseases. The three things which we need to take care of is undernutrition, non-communicable disease, and micronutrient deficiency. Therefore, we require pulses and legumes, which can provide micronutrients. We have vegetables and fruits, peanuts and gingery seeds and other nuts included for healthy fats, and plant-based oils in moderation to take care of the fat intake. Now, here is the my plate thing, which consists of cereals, pulses, milk. Everything is included in this diet. This is, of course, for a 2000 kilocalorie diet. And this is from the calories are from the food groups. And you can see the 14% of energy and 28% the food group for the fat is there, and proteins are around 14% of energy in a 2000 kilocalorie diet. Where we are slightly increasing the protein content because proteins will decrease the glycemic parameters. Now, I would like to present what India eats. Now, this is what is being recommended, which I just now presented in terms of energy in grams as well as kilocalories. It has been shown. Let's compare it with the urban and the rural diets. Now, here you have the urban diets, and you can see that the consumption of vegetables and fruits is very poor. And so also cereals and pulses are higher. And I'm sorry, I think I need to move this. Okay. And cereals and pulses and are much less in our diets, and therefore the protein may be measuring up to 10.5 to 11%. There is no specific protein deficiency, but the quality of the protein would be poor. And therefore now we recommend a ratio of either 2:1 or 3:1 of cereals, pulses, and also some amount of dairy. So for this will take care of the quality of the protein, though I know specifically that dairy is not conducive for climate change. Now, here is what the milk and milk products have been shown to be protective in intake of the milk and milk products. The risk of the diseases is much less. And fruits and vegetables and other food intakes on the risk of diabetes, we have shown when it is low, the risk is much higher as lower intakes of vegetables. So we need to increase the vegetables and fruits. Now, I don't want to go to this is the NFHS slide showing the prevalence of all diseases. It's a very busy slide, I'm sorry. I did not want to increase the slide. Now, here is the global warming potentials of various vegetarian and non-vegetarian diets done by an Indian, Pathak et al. As against Scarborough, here it shows that the vegetarian diets have much less greenhouse gas emissions, and also the global warming potentials are much lower in vegetarian diets as compared to ovo-vegetarians, non-vegetarian, even lacto-vegetarians, that's because of the milk. And of course, the non-vegetarian food is very high. Now, what are the guidelines actually? As I said, this has to be taken up by everybody. Unfortunately, this is unpublished data for the present. I cannot share with everybody. It will soon be published. It is under review process. As soon as it is over, it will be published. And my request is that this should be just not the NIN doing the entire thing. All the specialists, cardiovascular specialists or child, mother care, children care, everybody has to pitch in and do what is needed, because the guideline takes care of everything, eating a variety of foods or the diverse foods to satisfy the requirements of all the nutrients. And during pregnancy, extra food and healthcare to pregnant and lactating women. This, of course, is in the maternity field, ensuring exclusive breastfeeding for the first 6 months and then continue breastfeeding till 2 years, even though we may suggest weaning foods in that. Even weaning diets are going to be given in this particular volume now. Now start feeding homemade semi-solid complementary foods. That's what we want for the weaning diets, and ensure adequate and appropriate diets for children above 2 to 3 years of age and adolescents, both in health and sickness. That's one thing which needs to be stressed. Then we have eating plenty of vegetables and fruits. And that's where many people I have always been questioned why we are suggesting 500 grams of vegetables and fruits, out of which 400 are vegetables and different types of vegetables, green leafy and other vegetables. We wanted to avoid the, root vegetables can be taken, but potatoes, yam, things like that should be restricted. These are all there in the guidelines separately given. I have only given the guideline and the rationale. And use oils and fats in moderation. This everybody knows, but everybody uses sunflower oil or safflower oil, which is very high in N6. And therefore, the conversion to the long chain fatty acids is questionable. And therefore, it's better to take the traditional oils like the groundnut oil, sesame oil, even rice bran oil, because it contains the non-glyceride fraction oryzanol, which can reduce this thing. Well, each one is a subject by itself. Therefore, I'm not going into the details. Then obtain good quality proteins, the essential amino acids, that only can maintain the muscle mass. And it should consist of all essential amino acids, which can be obtained through combinations of cereals, pulses, and a little bit of milk. Otherwise, the quality of the protein may suffer, but then the quantity has to be increased further. We don't want to increase any quantity. Now, adopt a healthy lifestyle to prevent abdominal obesity, overweight, and overall obesity. That's the most important thing. I think you can never talk about a dietary guidelines without stressing on physical activity. And this is where I like the idea of implementation science. And this is where we are lacking. And I think almost 90% of the population, the study done by Anjana et al. Shows that they are very sedentary, even in the rural areas. And this is something which we need to look into. And the dietary guidelines always are associated with physical activity. course, restriction of salt, everybody is aware of, and we need to consume very safe and clean food so that we don't fall sick due to infections, and adopt very good cooking habits so that you don't lose some of these vitamins. We have given the details of it. And drinking adequate quantities of water. We prefer adequate water than other beverages which are being consumed, which are sometimes high in sugar and they're not good for health. And minimize the consumption of HFSS foods, that is high fat, sugar, salt foods that contribute to high intake of oils and fats, saturated salts. All the processed foods are definitely higher. Of course, many people may say we are against the industries. It's not so. The industry can prepare, if they want, a low fat, low salt, low sugar foods, which can of course be marketed. And then we should include nutrient-rich foods in the diets of elderly for health and wellness. Well, that's the gist of the things which I wanted to talk about today. And the most important thing is, once the dietary guidelines are published, I would request all the health personnel to look into that and suggest it to their patients or their subjects or their as a community participation. You said that's the most important thing, and give lectures on this so that it can be absorbed. The behavioral change communication methods, everybody now follows it, so everybody can follow this in their own respective fields and do the necessary mobilization of people to listen to these things and see that they practice it. Well, I think I don't want, of course, everything should be incorporated into the health sector, but already the ANMs and the ASHA workers are burdened with so many things. They may not be able to do it. It's even the medical community, I'm sorry to say, I belong to the medical community, don't bother so much about the diet. They'll simply tell something, but it's necessary to explain to them what is what and promote kitchen and horticulture activities in their own villages in the rural areas. It can be done. In fact, we are going to do now the study very soon so that we will know what are the bottlenecks, what are the barriers, and then we would be able to suggest much better things. Thank you all very much.
Thank you, ma'am. Dr. Kamla Krishnaswamy underlined what a French lawyer and gastronome, Jean Brillat-Savarin, stated very many years ago, about 200 years ago, stating that you are what you eat.
Yeah.
She gave in detail about what a proper diet should be, how much of non-vegetarian diet vis-a-vis meats actually contribute to climate change. She went along to tell us as to what a proper diet we should be following and ended up by saying that awareness is the key. It's for all of us to join hands in spreading the awareness of what a proper diet should be and what we should all be following. She also, taking off from where Dr. Arora left, she thinks it should be implemented and there should be a way of implementation which is also easy. Thank you, Dr. Kamla. So we will move on to the next.
Thank you very much for giving me this opportunity.
Thanks, Pam. We now move on to the next speaker, Dr. T.B. Shekhar, who is a professor and head, Department of Family and Generations at the International Institute of Population Studies, Mumbai. Over to you, Dr. Shekhar.
Namaskar, Om Namah Shivaya. Very good evening to all of you. I am grateful to Dr. Jaideep Menon and the organizers of this webinar for giving me this opportunity to interact with all of you on a very important concern. As all of you know, we have around 1.4 billion population in our country, or approximately 1,400 million inhabitants. And India is the world's largest or the most populous country now, recently surpassing China. In the 2011 census of India, the elderly population, what we call it as those who are aged 60 years and above, or what we call as the senior citizens, accounted for only 8% of total Indian population. That was roughly about 100 million elderly population. This scenario is going to change drastically in the coming 2 decades. The share of elderly population is projected to increase to 20%. That will be approximately 320 million elderly by 2050. So this dramatic and widespread nature of these ongoing demographic shifts indicates that the population aging challenges that India will face are both inevitable and exist on an enormous scale. Demographic and epidemiological transition has shifted a major share of country's burden of disease from children to the older population. Compared to the situation at the time of India's independence, the life expectancy of an average Indian has almost doubled now. We are certainly living more years than our previous generations. But the important question we need to ask is, are we living these extended years of life in a healthier condition? So the alarming nature of elderly population and the alarming number and its far-reaching implications call for a robust data on aging process. There are no comprehensive and internationally comparable national survey in India to examine the full range of topics necessary to understand the health, economic, social, and even psychological aspects of the aging process. As a response to this, in 2016, Government of India launched the Longitudinal Aging Study in India, popularly known as LASI, as a national survey of scientific investigation of the health, economic, and social determinants and consequences of population aging in India. LASI is a panel survey representative of older and elderly population of our country and its states. LASI Wave 1 covered a panel sample of 73,000 individuals aged 45 years and more, including 32,000 elderly persons from all states and union territories of India. LASI is India's first and the world's largest study that provides a longitudinal database for designing policies and programs for older population. LASI is internationally harmonized with the health and retirement studies of United States and its sister studies in around 47 countries across the world, which will enable us for cross-national and cross-cultural comparisons. We at IIPS, International Institute for Population Sciences, undertook the LASI survey in collaboration with Harvard School of Public Health and University of Southern California. And it's also funded by the Ministry of Health and Family Welfare, Government of India, and National Institute of Health. So we completed the LASI Wave 1 survey in 2017 and 18, and we are in the process of launching the Wave 2 survey this year. And this panel survey will continue for next 25 years. So I will highlight some of the health challenges for elderly population in India by using the emerging evidences we have from the LASI study. Overall in India, the self-reported prevalence of diagnosed cardiovascular diseases is around 36% among elderly. About a third of elderly have been diagnosed with hypertension and 5% were diagnosed with chronic heart diseases. In India, the self-reported prevalence of diabetes among elderly is 14%. And 8% of elderly reported chronic lung diseases. Around 3/4 of elderly who were diagnosed with chronic conditions have been treated for hypertension, chronic heart disease, diabetes, chronic lung disease, and cancer. Whereas the treatment rate of neurological and psychiatric disease among the elderly is lowest, only 40%. The treatment rate for all chronic health conditions is higher among the elderly in urban areas, those with better education, and those belong to economically better off households. Professor Srinath Reddy already highlighted the burden of communicable diseases in his opening remarks. So aging is associated with an increased risk of experiencing more than one chronic health condition. At the same time, that is what we call the multi-morbidity. According to our survey, around 1/4 of elderly in India have multimorbidities. The inclusion of biomarkers or the direct health examination is an important innovation in the LASI study, which is particularly important for a country like India due to low educational levels, limited awareness and access to healthcare services. So studies have reported that lower prevalence rates of self-reported diseases and inadequate disease diagnosis. So biomarker data allows for a more accurate and assessment of chronic disease burden than the self-reported health data. In India, the prevalence of high blood pressure is 36% among elderly population, which is much more than the self-reported levels. This is true for diabetes as well. So the prevalence of near and low distance vision among elderly is 32% and 15% respectively. And the prevalence of blindness among elderly is around 4%. More than 1/4 of elderly are underweight and 1/5 of elderly are overweight or obese in our country, indicating a dual burden of undernutrition as well as overnutrition among our senior citizens. Mental health is an integral part of the health and well-being of elderly, but largely neglected in Indian context. Depression, an important component of mental health, is also a leading cause of disability, dementia, and mortality. So the prevalence of probable major depression among elderly is 8%, which is 10 times higher than the self-reported prevalence of diagnosed depression, suggesting a higher burden of undiagnosed depression in India. Evidences also indicate that 1 in every 12 elderly have had probable major depression. So there are many efforts by Government of India. The National Program for Healthcare of Elderly is a major effort by the Health Ministry to address all these challenges. But the increasing cost of medical expenditure, mostly out-of-pocket health spending, pushing many families into the poverty trap. Unfortunately, only less than 20% of senior citizens are covered by any form of health insurance or health policies. So the growing elderly population on one side and the increasing health burden among elderly is on the other side. So the challenges ahead are really tremendous. It is our duty to ensure that our senior citizens at the last part of their life live with dignity, safety, and healthy. I believe C20 and all of us have an important role in fulfilling this enormous task. Thank you very much.
Thank you so much, sir, for sharing your thoughts. Especially since, as you mentioned, India has now become the largest population in the world. Our elderly population is going to proportionately increase. The fact that so many diseases, be it non-communicable diseases, probable major depression, and so many other conditions have such a high rate in the elderly population, along with the high cost of medical care. And as you mentioned, less than 20% of the elderly are actually covered by insurance. So sir's words really called out to all of us, all CSOs, all NGOs, all groups of the nation, both within India as well as outside, to find a solution to how we can best care for this precious part of our population. So thank you, sir. Next, I would like to introduce Dr. Umesh K. Bharati. He is the principal and state epidemiologist, State Institute of Health and Family Welfare, Himachal Pradesh. He's recognized for the path-breaking work that he has contributed to in the field of rabies. So over to you, sir. We're so happy to have you here today.
Thank you very much. I'm very sorry that I am in Delhi, actually attending some IAP conference. First of all, I must congratulate Amrita and especially Dr. Menon for starting this forum, because this is a platform where different groups and different experts can meet, and share their experiences. So I hope that this platform in the days to come would shift from talk to action, because unless there is action, there is nothing going to be happen now, practical. Since COVID-19, I think, can you hear me?
Yeah, we can.
Hello?
Go ahead,
Can you
Umesh,
hear
we can
me?
hear you. We can hear you.
Okay, thank you. So since COVID-19 started, there is a lot of talk of One Health, and holistic health now cannot be achieved without One Health, because if you take the problem of tuberculosis, it can't be achieved only in human beings. You have to look on the genetic aspect, bovine tuberculosis, and if you see rabies, you can't be rabies free without vaccinating dogs. Similarly, snake bite, you can't be just give anti-snake venom and get rid of snake bite. So all these areas we are working in the field, practically working. We have made a group of people, of geologists, of environmentalists, of herpetologists, of virologists, and veterinary people, and human health people, environmentalists. So all have to come at one platform to mitigate all these diseases in human beings as well as in animals. And another threat that I see in being in Himalayan region, being a resident of Himachal, that fast depleting glaciers and environmental degradation. In Shimla, there has been no snowfall this year. See, there is a rise of 0.9 degree temperature that has brought down snowfall from 300 millimeter to hardly 100 millimeters. So it is a warning. It's a warning in the days to come for natural resources, for water resources, and for changing pattern. Now the new diseases are coming. Human beings, animal beings, and even trees are getting dried up. New viruses, new fungi has come. So I think this holistic health is easier to say, but we need to work on ground. We need to work collaboratively with the veterinary people, with the environmentalists, with the I would say all type of people. Only then we can think of holistic health. It can't be achieved without a multidisciplinary team in action. I would say my emphasis always is on action. Otherwise, there is nothing saying presenting data and saying nothing is happening. We have to do it. We have to take the lead and do some action. So that is what my message is, and we are practically doing it in Himachal, whether it is tuberculosis, whether it is snake bite, whether it is rabies, whether it is environmental protection. So we are doing it in collaboration with so many NGOs, with so many different key people, including administration. And once we do things, we take the lead, then we don't get any obstacles from the administration also, because they know they are working. So when we start doing things, though the government obstacles and government people, they are always there to help you. So that's what I would request C20 to make a action plan, so that we can all contribute and actually do something on the ground. Thank you.
Thank you, Dr. Umesh, for that very brief presentation. What Dr. Umesh highlighted is that that we have to be able to implement whatever policy drafts or policy packs are made. The proof is actually in that, if implemented, and if it's seen to be have some good on the society and community around, it's only then that there's a worth to the policy pack. Dr. Umesh highlighted his work, briefly touched on his work in rabies, highlighting that if rabies were to be eradicated or controlled, if not eradicated, it is imperative that the same be done in animal species as well. The same would apply to a whole host of other conditions. And like he said, this was highlighted during the COVID, when it became so apparent that the world is so small a place, and what affects one affects the other, whether it's from plants to animals, animals to humans, or the reverse. Thank you, Dr. Umesh, and we shall keep you informed, and you will be very much a part of the policy drafting team as well. So with that, we move on to the last speaker for the day, Dr. N. Ramanohar, who is the Director, Amrita Center for Advanced Research in Ayurveda from the Amrita School of Ayurveda. The e-floor is yours, Dr. Ramanohar.
Thank you. I'm really honored to speak on this platform where, eminent and distinguished personalities in the field of healthcare share their views. I'll try to give an overview of how traditional medicine can contribute to our efforts in bringing holistic healthcare to the global population. We know that molecular biology and biochemistry have greatly enhanced our understanding and treatment of diseases. But despite the phenomenal progress in medical science, there are treatment gaps and unmet needs in global healthcare. And in this backdrop, the use of traditional medicines has expanded globally and is also gaining popularity in the last few decades. I mean, specifically, these practices have not only continued to be used for primary health care of the poor in developing countries, they've also been used in other countries where conventional medicines are predominant in the healthcare system. So we can say that a large segment of the population still depends on traditional medicine or so-called alternative or complementary medicine as a preferred form of healthcare. And this is quite significant if you look at the whole global population. So in some parts of the world, most people continue to rely on their own traditional medicine to meet primary healthcare needs. And when we adopt traditional medicine outside of its traditional culture, we refer to it as complementary and alternative medicine. And some data is available on the prevalence of traditional medicine use, especially in low-income countries, and it is estimated to be between 40% to 71%. The WHO projects it to be at least 80%. And 170 of the 194 WHO member states have also reported using traditional medicine. And in this backdrop, there is a lot of interest and demand for creating a body of reliable evidence and data on traditional medicine practices and products. Among others, the most widely used traditional medicinal systems today include those of China, India, and Africa. And recently, the Global Center for Traditional Medicine of the WHO is getting established, in Jamnagar, Gujarat, India. So if you look at traditional medicine, it covers the sum total of the knowledge, skills, practices, which are based on the theories, beliefs, and experiences indigenous to different cultures. And all these methods that are used for the maintenance of health, as well as prevention, diagnosis, improvement, or treatment of physical and mental illness, are all together called as traditional medicines. It's important to note that some traditional medicine systems are supported by huge volumes of literature and records of theoretical concepts and practical skills, while others are passed down from generation to generation through verbal teaching. So traditional medicine seems to have a great potential to strengthen this idea of holistic health because of the way it has developed, in the past. Holistic medicine, we could define it as an approach to wellness that addresses physical, mental, emotional, social, and spiritual components. And therefore, it includes many disciplines, even religions, spiritual traditions, and cultures to heal people. And it also includes environment. So it gives us a very inclusive framework. And holistic health assumes importance in the context of universal health coverage, the SDG 3, and themes of One Earth and One Health. And I would like to emphasize that if properly integrated, traditional systems of medicine can play a major role in making holistic health an integral part of global healthcare system. The systems of medicine like Ayurveda are actually based on a nature-centric, person-centric approaches that also gives a lot of emphasis on preventive healthcare. So with this significant expansion in the use of traditional medicines worldwide, safety, efficacy, and quality control of herbal medicines and traditional procedure-based therapies have also become important concerns for many of these countries. There are people spending out of the pocket to access traditional or alternative systems, even in developed countries like the US. So the WHO has also been increasingly involved in developing international standards and technical guidelines for these types of medicines. and also an increase in communication and cooperation between countries. So the challenge now is to ensure that traditional medicines are used properly and to determine how research and evaluation of traditional medicine should be carried out. So access to diverse approaches to healthcare integrated within an evidence-based framework, a patient-centric approach rather than a system-centric approach to healthcare, and community empowerment and self-reliance are some of the relevant themes that emerge when we look at traditional medicine and holistic health. It also needs to be emphasized that we have put curative medicine before prevention. And this has led to neglect of approaches in nurturing positive states of health and wellness, which has always been emphasized in traditional systems of medicine. And there is really a need, as has been pointed out by the previous speakers, to nurture healthy lifestyles, diet habits, and home remedies to prevent diseases, which have been part and parcel of traditional healthcare approaches. Systems of medicine like Ayurveda has also emphasized on food diversity, and there are very interesting approaches to balanced nutrition that are offered by these traditional systems. So this was also pointed out that non-communicable diseases like heart disease, cancer, diabetes, and respiratory diseases account for around 75% of global morbidity and mortality. And such chronic conditions also require palliative care and an approach to improve quality of life, and definitely treatment approaches that integrate traditional medical practices selectively can help us address the burden of NCDs more effectively. So India actually brings a unique vision for holistic health to G20, and with India being one of the rare examples of medical pluralism, with diverse health systems having legal sanctions, and Ayush systems like which including Ayurveda, Unani, Siddha, Soa Rigpa, naturopathy, homeopathy, and yoga. Almost the entire spectrum of complementary and alternative medicine is practiced in India, but we need to really effectively integrate them into the healthcare system. I mean, these systems work in silos, so that is going to be the challenge of the future, so that people can take more informed decisions and choices when it comes to dealing with their health care. And I think this integration can help to bring a holistic perspective across holistic health verticals, including mental health, mother and child health, elderly care, and so on. So to conclude, the rich experiences of Ayush civil society organizations in India can offer very interesting micro success stories or udaharans that can be developed into strategies for global implementation. So through our C20 initiatives on holistic health, I hope we can all come together to voice the people's aspirations for holistic health care delivery systems, even as we reach out across the globe to bring, global perspectives. Thank you.
Dr. Jaideep, you have been muted.
Dr. Ram Manohar, thank you a lot. His was the last talk in the series, and it's not intentional that we don't have a speaker from mental health. Actually, Dr. Soumitra Patare was supposed to have spoken, but his flight got delayed apparently, and which is why he's not been able to join us. Dr. Ram Manohar reiterated what two other speakers had actually spoken about, that it's a more holistic approach to health. It is not an organ-centric approach that one requires in this present day. And reductionist has its own advantages, and there are huge disadvantages also. One ought to be looking at it as an individual or a patient as a whole, and not as a part or as an organ. And I think we could all work together to seeing an individual as a whole, and a more focused approach to an individual as a patient, because every individual differs from other in some way or the other. So I think we end with this. Let me conclude by stating that all the sessions have been very insightful and have helped actually lay the template and tenor for future events. A series of webinars, seminars, and public awareness programs have been planned for the next 6 months. We count on all your advice, support, and insight for framing policy, which should not only be inclusive, but should also be implementable and, most importantly, a value to society so as to make the world a better and more equitable one to live in. Priya?
I would just like to conclude the session by saying that we have shared the registration links in the group chat. Please do register, because as all of our eminent speakers mentioned, it's when we work together and when we share our stories, our success stories on implementation in the field of public health, that's when we can really make a difference. Also, we will be having announcements for our webinars, our public engagement activities. All of that will also be shown regularly on the website. So please do check us out. Please do give us your feedback and comments. And I'm sure all of us working together, all public health experts, as well as people just interested in one health of society as a whole, I'm sure we can do a lot to make this world a better place. So thank you so much. Om Shanti, Shanti, Shanti. Good evening and good night to everyone. Om Amriteshwariye Namaha.